first, I'd just like to introduce a little bit about Results Canada before we get started. So next slide, please. There we go. So Results Canada, for those of you who are not familiar, I do see we have some folks from Results UK, which is fantastic. Is we're a grassroots advocacy organization committed to creating the political will to end extreme poverty. We do this by empowering engaged citizens to use their voices to influence decision makers and combine that with strategic advocacy efforts from our national office to leverage resources for cost-effective, proven policies and programs that have a real impact in the world. We work across issues including global health, education, and economic opportunity, but are particularly passionate about immunization, which is why we're here. We know the incredible role that vaccines have had in saving and improving the lives of millions of people around the globe, and we want to make sure that we maintain support for that. So actually, in the past few months, we were in the midst of an immunization campaign for continued Canadian support to immunization, including trying to get funding to organizations like Gavi, the Vaccine Alliance, and the Global Polio Eradication Initiative when COVID-19 hit. Like everyone, we're extremely concerned about the impacts that COVID is having at home and abroad. We know that the creation and distribution of a vaccine is going to be integral to stopping the pandemic, but we also need to pay attention to the impacts that it's having on current immunization programming. And that's why we're here right now. So we've all seen the headlines. We're worried about what's going to happen if there's going to be outbreaks of diseases like measles and polio. And so what we've done is we've gathered experts here today from all over the world that are going to share some of their perspectives, experiences, and recommendations for what we can do to ensure that we don't lose the momentum in the fight against vaccine-preventable disease. So thank you so much for joining today. We're going to get started. For those that might have just joined in the last few minutes, I'm Taryn from Results Canada. Kind reminder to mute yourselves, and you can put any questions in the chat box. So next slide, so agenda, you can see we're just going to jump into some short presentations from a variety of experts from around the globe and then have questions at the end. So please do put them in the chat box. First up, we have Dr. Chizoba Wanodi from Nigeria. So if you could please introduce yourself, and we're ready for your intervention. Thank you.
Hello, everyone. My name is Chizoba Wanodi. Can I share my screen, please?
Sure, you should be able to share your screen now. If you go down to the green, there's a green screen share box on the bottom.
Okay. Find it. Can you see it? Can you see my screen now?
Yes, that's working.
Okay. Okay. Hi, everyone. My name is Chizoba Wanodi. I am with the Johns Hopkins School of Public Health, the International Vaccine Access Center, and I am the country director for Nigeria programs. I'm also a member of the Gavi CSO constituency platform, and that's made up of several organizations involved in immunization. So what I want to talk to you today about is how important Gavi is to the immunization program in Nigeria, and how critical the support for Gavi is, why it needs to be strengthened, why it needs to be continued even in this era of COVID-19. So here you see that Nigeria is a big country. People say that 1 out of every 4 Black men, 1 person is a Nigerian. So it's no surprise that there are 200 million people in Nigeria. Every year, almost 8 million children are born. So this means that there is a lot of lives to be saved in Nigeria. Unfortunately, more than 800,000 children die every year before their 5th birthday. And many of the causes of these deaths are vaccine preventable. So in the slide down, you will see, in the slide that I'm showing, you see trends in the common causes of childhood deaths in Nigeria over time. And what you will notice is that the diseases that are vaccine preventable, like pneumonia, diarrhea, measles, there have been some improvement over time. And so vaccines have really contributed to the decline in child mortality that we've seen in the last 15 years, about 50% decline in child mortality. And a lot of that is attributable to vaccines. But the problem is that immunization coverage in Nigeria is still not optimal. Although things are improving, between 2016 and 2018, we've seen a rise in immunization coverage from 33% to 50%. However, despite that good news, we have to point out that nearly 4 million children remain under-vaccinated, and 1.5 million children receive 0 vaccine doses at all. So now layer that on top, layer COVID-19 on top, and you find that one of the reasons why kids are not vaccinated, obviously, is the weak health systems. And then comes COVID-19. So far in Nigeria, there are 627 cases confirmed, 21 deaths, but the cases are rising sharply. It's as if we're going into the exponential phase of the COVID pandemic in Nigeria. And it's had its effect on the health systems. First of all, there's a lot of diversion of funding and attention to the COVID response. And not just funding, even the health staff and program staff are focusing on COVID-19. I mean, for good reason, because we don't want a pandemic to overwhelm us. Again, at the health facility level, services are actually reduced, not just because people are not coming, but also because health workers who are supposed to provide the services are not, they don't have sufficient personal protective equipment. So, in some hospitals, some health workers are not coming and they are not attending to routine cases. So in the community as well, there are concerns about the safety of going to health facilities to receive services that are not necessarily life-threatening or emergency services. So immunization is one of them. So our task, therefore, is to make sure that even as we shore up our health system and we respond to the COVID pandemic, that we do not let the immunization system fall apart, because we will lose the gains that we've made over time. So Gavi, here in comes Gavi. Gavi is a critical partner in supporting Nigeria immunization program and their primary health care program, even in this era of COVID. So we know that Gavi is currently supporting Nigeria to shore up the health systems against coronavirus, and with their support, with allowing some part of the health system strengthening fund to be repurposed, we know that they will be there to help rebuild even after the coronavirus, after the immediate phase of the coronavirus response, where we need to then catch up children with immunizations that they've missed. This Gavi support is really critical to ensure that other infectious diseases don't flare up. For example, measles. You saw the sharp decline in measles deaths, and that's because of vaccines. So if kids are not getting those vaccines, there are real fears that there might be an outbreak of measles. And I tell you, more children will die from measles than they will from coronavirus if we don't prevent that from happening. So Gavi is really good at leveraging private sector funding and expertise to really optimize the immunization program. So we're looking towards a lot of innovation to come from that end, leveraging the assets that Gavi has. Another thing we're looking towards Gavi is that vaccines ultimately will be the solution to COVID-19. So we know that there are 52 candidate vaccines under production, under development. And at the time we finally have a vaccine, we're hoping that Gavi will be provided the support they need, the funding support they need to ensure that poor countries like Nigeria are also, in line for vaccines. We don't want what has happened with previous vaccines like pneumococcal, hepatitis vaccine and Hib vaccine, where it took about 10 to 12 to 15 years before countries like Nigeria got vaccines that they really, really needed. So accelerating access and affordable access to the COVID-19 vaccine is a critical role that Gavi is going to play, and we look forward to them being supported to do that. The final thing is that with the COVID-19, in Nigeria, we have some states that are locked down. So people are not allowed to go out except for food and things like that. We know that in such situations, you may have rise in domestic violence because you're locking down victims with their perpetrators. And we know that it's important to put a gender lens in whatever response we're doing. So we're happy that gender is an important aspect of how Gavi is looking at the support that they're giving countries and making sure that in determining how COVID-19 response will be rolled out, that gender is given its pride of place to ensure that we do no harm while containing this epidemic. So what I would like to say, therefore, is that for the Gavi replenishment, I would really encourage members of this Zoom call to give a strong voice to the call to replenish Gavi, because it's really, really important to help us protect the next generation. For me as a Nigerian, I know that Nigeria is one of the Gavi priority countries because of the sheer volume of the population, and Gavi has invested more than $1 billion in the Nigeria immunization system since 2001. Not just the money that Gavi has invested is important, but also the fact that Gavi's investment is able to attract additional funding from the Nigerian government. So 2 years ago, Gavi put $1 billion on the table, and with that, they were able to attract an additional $2 billion from the Nigerian government, which would have been hard to do without that, without that incentive. Now, it's not just about money, it's also about lives saved. 3.9 million children have received life-saving vaccines from the Gavi support since 2018. That's more than 15% of immunized children in the entire 40 Gavi-supported countries. So you see why Nigeria is really important. So, like I said, Gavi has continued to engage with the national and state government to ensure that the gains that we've made over time are not lost, that they are solidified, and in fact, that they are improved. So with a focus on gender, with a focus on equity, making sure that that 1.5 million children who have received no vaccines at all, that they get their chance at life, they get their shot at life. So we really appreciate all those strategies that are being brought to bear. Now, a critical thing that Gavi has done recently is focusing at the subnational level, ensuring that where there are inequities in access to vaccination. I didn't show you that slide, but if you break down the immunization coverage of Nigeria, you will find that in the northern states of the country, the vaccination coverage is quite low. In 2016, there was a state that had a 3% coverage. And that same 2016, another state had an 80% coverage. So there's a lot of inequality. So Gavi is now going beyond the national level at the subnational level and working with particular states to shore up their immunization program. Now,
just one minute left and then we'll move on, okay?
1 minute, sure. Yeah. And this is my last slide. So what I want to then emphasize is that Canada is a leader in supporting Gavi's work, and we want to thank Canada for that, and we want to encourage Canada to continue to do that. How have they been a leader? They've tripled their contribution to Gavi since inception. They continue to commit to immunization, equity, and gender. And Canada was a leading light in ensuring the advanced market commitment for pneumococcal vaccine. This AMC was responsible for shortening the time between when poor countries got access to the pneumococcal vaccine and when, from the time it was released in rich countries. So I want to conclude by saying to you all to say thank you for the work that you do. Thank you for the advocacy that you do. There's still much more that we need to do to support Gavi and support the mission to leave no child behind with immunization. God bless you. Thank you.
Thank you so much. And those are very helpful slides that we'll make sure we'll circulate. And as mentioned, if you have specific questions, we can put them in the chat box as well and talk more about Gavi later. So next we're going to move on to Violaine Messager, who's going to speak to us in her role in the World Health Organization and specifically on the Global Polio Eradication Initiative.
Hello, and sorry for the delay, and I'll try to, yes.
There we go. Hi.
Well, thank you so much for the opportunity. Much appreciated. As Darren mentioned, my name is Violaine Messager. I work at the Global Polio Eradication Initiative. I'm very pleased to be with you, and I'll start with a bit of a travel back in time to draw a few parallels between the fights against COVID-19 and polio. And this idea was very much given to me by an article over the weekend in Canadian media. Basically, when in the 1930s until the 1950s, Canadians faced multiple polio outbreaks. Back then, the polio virus was not so well known. It was affecting thousands and thousands of children. And as government officials realized what was going on, just a little bit like we're seeing with COVID right now, that most carriers were actually not showing symptoms of the disease. They were basically closing down swimming pools, parks, everything. Children and adults that were the most severely affected were placed in iron lungs, not ventilators yet, but what we had at the time to try and survive. And this very simply because there was no treatment and there was no vaccine. So just as a start, the COVID-19 pandemic reminds us first that we should not walk back from the tangible progress we've made, but second and actually foremost, because we do not have right now vaccines or treatments, and people are very sadly passing away and health systems are overwhelmed, we get reminded of the power of vaccines. So this is really something that we need to really be able to take a step back about and think about further. So perhaps just to finish the travel back in time, what made a difference back then in the 1930s, 1950s in Canada to end the polio tragedy? First of all, dedicated Canadian researchers made some scientific breakthroughs. They made mass global production of polio vaccines possible. Some of the names didn't make it to history books. Some the brother scientists on the other side of the border a bit stole the show, but actually some of the Canadian scientists really made a deal maker. It also took some very courageous political decisions from then Minister of Health, Paul Martin Sr., who decided to maintain the clinical trials and the production in spite of fears and rumors. And of course, it took a strong health system that was learning lessons as it went. And as a result of that, Canada was able to save multiple lives and thrive during the following decades. Many of the challenges faced then remind us of today: ventilators, desperate search for vaccine, for treatment, maintaining health system above the line of collapse, and of course, trying to manage the cascading effects of economic recession on the poorest. A few days ago, Minister Gould delivered a very important message about COVID-19. Basically, it needs to be defeated everywhere to keep Canadians healthy once and for all. And this very much echoes the message that the Global Polio Eradication Initiative has been promoting in its fight against the polio virus in the last decades. The GPI has made great strides towards eradicating polio, of course, with the support of the Canadian government. And it has once again responded present to the call of duty, as it did during the Ebola crisis, especially in Nigeria, where it played a key role in interrupting transmission while Ebola was really starting in the first footsteps. And my colleague Melissa knows way more about Nigeria than I ever will. So she'll be able to expand on COVID, polio in Nigeria. The G7, G20 have recognized many times the essential contribution of the polio infrastructure to strong and resilient health systems and to global health security. And why? Basically because polio is being eradicated, meaning that we need to focus on the hardest to reach, on the last missed children. So in many of these areas that are fragile, vulnerable, where there's barely the embryo of a health system, polio has gained some access and has some assets available that it can put to fruition for other programs. I'll close with a brief summary of what the GPI governance has decided in the last few weeks. So the Polio Oversight Board, which governs WHO, UNICEF, CDC, the Bill and Melinda Gates Foundation, Rotary, and more recently Gavi, has taken a very difficult but very necessary decision to suspend immunization campaigns. Of course, we should not in any way contribute to transmission of COVID-19. It also took the bold decision to repurpose all available capacity for COVID-19 response. As an example, GPI has essential disease surveillance infrastructure, laboratories, capacity, medical officers able to proceed with testing in approximately 70 of the poorest countries. These laboratories will be doubling up, continuing basic polio surveillance while supporting the life-saving work of detecting COVID-19 and tracing contacts to reduce the spread of the deadly disease, which, as we know, it's hitting the industrialized world badly, and the risks for Africa and other regions are very extreme. In our side, on the GPI side, we're aware of at least right now 13 countries where health workers, community mobilizers, national and provincial coordination structures are being repurposed. And of course, there will be more as more countries prepare their plans. Sadly, while we must all act in solidarity today, the pause of campaigns, the pause of polio campaigns means that in a few months, we will see many more polio cases in the world. And we will need to address the situation then when it is possible again. For this, we will need to continue to rely on our most generous donors, including the Canadian government. As I mentioned earlier, Canada has played a critical role from Dr. Leone Farrell in the 50s to Paul Martin, Jr., Senior, PM Trudeau, and many, many, many Canadian advocates. And I'll thank you in closing, and of course, my colleague Melissa from UNICEF will be able to share many more details about how it works in practice in the field. Thank you so much.
Thank you so much for that, Vio. And as mentioned, we're going to move on to Melissa Corkum from UNICEF, who has a lot of direct experience working in countries like Nigeria and Afghanistan on polio programming. Thanks.
Hi, everybody, and greetings from Nova Scotia in Canada. I'll share a little bit of experience and how I see the impact of COVID on polio eradication in particular. And I've been working in the polio program for the past 17 years, and mainly in countries such as Nigeria, the first speaker, Afghanistan, and Pakistan. I think there's no doubt that COVID will have a profound impact on all of our efforts, not just today, but in the future of polio eradication, but other immunization efforts. And as Vio mentioned, the program's response, we took a very difficult decision, knowing that more and more children will be affected and paralyzed by polio, but based on two principles. We have a public health imperative as public health workers running disease eradication programs. We really need to make sure all of our assets, our people, our physical assets, are directly supporting the program. And two, when the emergency ends, and we know it will end, we'll be ready with a sense of urgency, because we'll have another emergency on our hands with the expansion of polio into new and existing geographies. So when the fallout from COVID is over, we will have more, and we need to be poised and ready for action. So those are the two key core principles of our polio response. So how is COVID affecting the polio program? As Vio mentioned, we've had to take a pause in the program in both the countries like Afghanistan and Pakistan with endemic polio, but also in all the other outbreak countries like DRC, Chad, Angola. And all of those mass campaigns from polio have been put on hold for taking a break. Because why? Because the polio approach is a house-to-house campaign with house workers visiting the every household. Social mobilizers going door to door and engaging in areas of risk. This goes directly against the approach that we're talking about, physical distancing. So there's a natural tension in the work that we're doing in delivering immunization at the doorstep, the cornerstone of the polio strategy, let alone the need to practice hand washing at every encounter and opportunity. So with this in mind, we've suspended the program and anticipate an upsurge of polio cases in new and existing places. But all of our people will be actively involved in supporting the surveillance and vaccine management, supply chain management in country. My team, I have 2 colleagues that I had deployed to DRC and Chad to support upcoming polio campaigns. They're now repurposed and are actively helping the government of DRC and Chad to set up risk communication, community engagement programs, as well as the logistics groups that are tailored to the COVID response. And like COVID, polio is also a public health emergency of international concern, and we have a wealth of experience and determined people in country and at all levels. We have many examples of how the polio program is in countries that are dear to my heart, and I've spent decades working in them, of how the polio people are rolling up their sleeves. They have the experience, they have the know-how, they know where the hard-to-reach people are, but we've had to rethink how they work. We can't go house to house. All of our approach for, certainly for UNICEF in social mobilization, community engagement, has to be rethought in an environment where we have to physical distance. So in Afghanistan, nearly 4,000 polio social mobilizers, many of them women, have been equipped with protective gear, physical distancing, and promoting hygiene and distancing in their communities. Not an easy challenge in a complex environment like Afghanistan. They're also distributing soaps and trying to support routine immunization in the pause of vaccination activities, the campaigns. In Pakistan, we have thousands of community-based vaccination teams who are supporting the case tracing, the surveillance activities, and reporting at-risk and suspected corona cases. And they've all been trained on with the unique requirements of COVID, and we're taking our duty of care. Huge networks are really being co-opted actively into the response in these key countries. And in Pakistan, there's a huge call center that was established to respond to, AFP cases, acute flaccid paralysis, and to community needs for immunization. That call center is now taking more than 70,000 calls every day of concerns from the communities. In Nigeria, huge networks of traditional and religious leaders are being used or engaged to reach into communities in different ways. They have to physical distance, so through social media, announcements, and through mass media campaigns. More than 20,000 volunteer community mobilizers in northern Nigeria, they're all women, are all promoting hygiene practices and physical distancing. This is serving more than 22 million people in northern Nigeria. And I think, the engagement of the polio networks in these countries can also then, when we do resume, help build trust and to rethink and rebuild trust in vaccination. And in some of these countries, Afghanistan, Pakistan in particular, we've seen pretty significant trust deficits as particularly for polio activities. So perhaps their engagement and active fight against COVID can help when we do come back. And while fighting COVID, the team is preparing to come back, keeping in mind the need to come back stronger. We won't know what the post-COVID world will look like. We will likely have a tired health system. We may face trust deficits in communities where perhaps their perception that the system didn't respond to their needs isn't met. We are rethinking our delivery strategies, and we may need to consider areas where we have faced physical distancing. What our strategies will need to be tailored in these new contexts. And we hope we can use the opportunity to reposition the value of immunization and in this time of a pause. We're preparing as a polio program to introduce a new vaccine later in the year. This pause will allow us to prepare for a smooth introduction with the countries where it will be used. We hope to keep up the momentum on these strategic areas to minimize the loss of ground, and we will ensure that we will come back stronger and faster when the emergency subsides. And before finishing, I'd like to appreciate the Canadian government and organizations like Results Canada for actively championing polio and broader immunization, certainly in the contexts where I've worked, Afghanistan, Nigeria. They're very active partners, and particularly promoting gender, and which has certainly been a challenge in these contexts. So I think together we can come back stronger, promoting the value of immunization and rethinking how and improve on the way we deliver immunization in a post-COVID world. Thank you.
Thank you so much for sharing your experience. And also just wanted to express sympathies with what's happening in Nova Scotia right now. If people haven't seen, there was a really horrific mass shooting last night. So just solidarity with you.
Thank you.
Now we're going to travel to Nigeria, and we're going to hear from Elizabeth Muchoki, who actually works for CANCO, which was one of Results Canada's and Results UK's sister advocacy organizations. So we're going to hear a little bit about what's happening there.
Hi everyone. My name is Elizabeth Muchoki. I work with an organization called CANCO, and I'm not from Nigeria.
Oh, sorry, Kenya.
Yes.
I was looking at Chizoba.
Maybe just to mention briefly, what I do, I am the project manager for the immunization and vaccines program. Gavi has funded Kenya, and we are the only CSO that is getting money directly from Gavi to implement the community social mobilization with the main role or main aim of increasing demand for immunization. Because interestingly, Gavi is funding 90% of Kenya's vaccine supply and equipment, and then the government takes care of the healthcare workers. But as much as the supply side is existent, we have a very high resistance and hesitancy in terms of seeking for the vaccine services or the immunization services. And this is where now CANCO comes in to try and create and increase the demand by reducing the hesitancy and the resistance. Well, CANCO is a consortium organization. Our vision is healthy people, empowered communities. And that is what I'm only going to talk about that for now, because we are not here to discuss about CANCO. I want to talk about immunization challenges in the wake of COVID-19 in Kenya, as we are right now. And I want to start by saying that the poorest groups not only bear high risks for immunization preventable diseases, but once they develop a disease, they also face higher health and economic impacts. Currently, more than 40% of the Kenyan population live below the poverty line, less than $1 a day. And things are getting tougher with COVID, whereby most of them being casual laborers have ended up losing their jobs. So we are expecting the situation is actually going to get worse instead of improving. And these same poor people have less access to medical care. Hence, there are more levels of mobility, mortality, and even disability in those areas. So currently in Kenya, what has happened is that they're saying we are having 280 plus cases of COVID as of today's updates. And the most scariest thing is that Kenyans don't seem to be taking it seriously. Now, it has taken a toll on immunization because it has started to affect the mothers and the guardians and every other person who takes care of a small child. There is a lot of stigma, there is a lot of worry, there is a lot of fear. And so the guardians are opting to, in the name of social distancing or physical distancing, stay at home and not actually bring those children to the facilities for immunization. Case in point, in the last 2 months, we have seen a drop in the immunization coverage. And I'm going to use the informal settlements of Nairobi, whereby some areas were at 60%, they have gone back to almost 40% immunization coverage. This is not very good because the same informal settlements are the ones that are known to have outbreaks of diseases like polio, cholera, and measles. And my greatest worry is that maybe in the next or by the end of this month, we will actually start experiencing those things. It is also at a time whereby the weather in Kenya or the climate is not favorable. We are having serious rains, we have poor drainage, and there's flooding. So It's like we are going to have a very overstretched system right now. And I'm not sure what we can handle. Is it COVID? Is it the outbreaks that will happen? That is something that I'm sure the Kenyan government right now is worrying and having sleepless nights about. However, one thing that is clear is that no one will be left untouched by the consequences of the COVID-19 pandemic. And the impact will be felt especially in countries like Kenya, which as much as they are middle income, they are low income as far as the majority is concerned. And we have extreme poverty, and this is going to breed illnesses and disease. It's going to strain the budgets, home out-of-pocket expenditures, and also it has already started overstretching our own health systems. Now, the other issue that we are facing is that due to a lot of trainings for COVID-19, with our overly stretched human resources for health because they are not adequate, we are having several rural facilities being closed down because this one healthcare worker who works there has been taken to a certain center to be trained for COVID-19. Hence, mothers will come back and then they are turned away and the children don't end up getting immunized. And then these mothers tomorrow probably opt not to come back because they're also not sure whether they'll find the healthcare worker. And so this is also affecting immunization. On the other side, we are also having the healthcare workers thinking that immunization is not an emergency service. And in the fear of COVID, they are opting to not offer services unless they're emergency services. Now, I don't know who is going to be a voice to these children who tend to get turned away and they are voiceless because they are below 5, just because someone is scared that they might contract COVID-19. And it's become a big thing because there was a facility in one of our informal settlements whereby mothers went and the healthcare provider there said they're only attending to emergency cases whereby maybe someone has a cut or they have a life-threatening condition at that particular moment, and they didn't think that emergency was one of those services they needed to offer. So that is also something that COVID has brought our way, which is not a very, very good thing. Now, the other thing is that there is a huge concern. We have counties that have conflicts and they have high levels of insecurity. Already this led to poor performance as far as immunization is concerned. And now with COVID, we already have a case in one of the counties called Mandera. It has already heightened the issues. So what has happened is that facilities have closed down in areas where insecurity is an issue. And then even those that were now near places in towns, they have closed down due to the fear of COVID-19. It's sad because besides immunization, the people there are also being denied all the other health services. And our Kenyan constitution says that health is a right of each and every other person. So the lack of or the inaccessibility to health services is great or gravely affecting immunization in Kenya. And currently CSOs have started to talk about it, but there is also a bridge, would I call it a ridge, or there is a conflict of interest when it comes to the county leaders thinking that CSOs are not doing enough or they don't need to be in this COVID-19 reaction. Let me call it a reaction because it has already happened. And so they tend to downplay or badmouth CSOs. And this has created an interesting environment whereby CSOs are trying their very best to advocate for more resources towards addressing COVID-19, addressing basic services like immunization and also outpatient services for children in the rural areas. But then the county leadership does not appreciate that this is a priority for them to uphold. In this frenzy of everyone thinking that COVID is the only important thing, then I'm left wondering what happens after COVID is dealt with. And then we have a resurge of conditions that we could have prevented with continued or continuous immunization services. So that has also come out as a serious challenge. And finally, we have the religious leaders who, with this COVID, they have been told to close up their churches, no congregations meeting in one place. And it's interesting that one person would say they will die either way and still ask people to congregate. and there was such a challenge, one church, and they were found. And there are others that have also written letters to tell their congregants that they have been allowed to reopen the churches. And these are places whereby COVID-19 infections are on the rise. And so this has become very, very interesting, whereby a religious leader does not value the safety of the congregants and ends up thinking that them holding the services is better. So out of all this, what CANCO and in the space of CSOs is trying to do is do serious sensitization for CHVs who have now been left at the front line or the first point of care in the communities, including incorporation of the local authorities, so that they can continue to do community social mobilization, not only for immunization, but for all other health services, including GBV, which is on the rise in Kenya as we speak. I don't know if you've been following the news, but if you have, you will see that women are now, the violence rate has increased with more than 10%, just because of this partial lockdown of COVID. So CANCO with other CSOs are sensitizing CHVs in terms of, as much as they are preventing or protecting themselves from contracting COVID-19, they understand that they need to continue with community engagement and delivering important health information to their communities. CANCO, together with other CSOs, have also tried to support the government in provision of PPEs for the healthcare workers who are in the rural facilities and the informal settlements. And finally, we are trying to hold virtual meetings with high-level members, that's our members of parliament, our county health management teams, so that we can be able to continue sensitizing them on how best to handle the COVID-19 pandemic, and also on how they should not forego all the other good deeds that they have been doing as far as health, provision of quality health services is concerned, just because of COVID-19. And for them to understand that it should be integrated care, because this same mother who will get COVID is the same mother whose kid needs to be protected through immunization for many other diseases. And I want to end there, but give my regards to Results UK for this webinar, and also for their championing the Gavi replenishment. Gavi is really doing some very good work in Kenya. As I've said, 90% of our vaccine supplies, especially the new vaccines, the rotavirus, the pneumococcal vaccines, the HPV vaccines, are all being procured by Gavi. And so we wouldn't want to lose that. So thank you very much for that good work that you're doing. Taryn, I think I'm done.
Great, thank you so much. That was really good presentation, and I think it's a fantastic segue, because I appreciated how you talked about the secondary impacts that COVID is having on different aspects. And Julie Truelove from WaterAid Canada is actually going to speak about the intersections of immunization and water sanitation and hygiene. So hi, Julie.
Hi, thanks, Taryn. I hope everyone can hear me okay. I've had some Wi-Fi issues today, so thanks very much to Results for bringing this conversation together. It's been really interesting to listen to everyone's inflections on this. And so WaterAid has been exploring immunization and integration of WASH and immunization in our health systems work for a number of years. And we also find ourselves at this critical moment for potentially revolutionizing hygiene integration, both across immunization and other health interventions. So for a bit of background, just in February, WaterAid and the London School of Hygiene and Tropical Medicine convened a roundtable on integration of WASH and immunization. And while this was just prior to the global onset of COVID, the findings have quickly become more timely. The roundtable was building on research that's been carried out by WaterAid and our behavior change specialist in Nepal since 2012 that focused on integrating hygiene behavior change with the National Routine Immunization System, which initially was in anticipation of the launch of the rotavirus vaccine in 2018. Just very, very briefly, there's a longer background to it, but most often mothers and caregivers would participate in hygiene behavior change sessions with each clinic visit for the routine immunizations, and there's much more behind it, but that was the gist of it. So the model found a number of benefits that included efficiency of the vaccine use for service providers, given that people were incentivized to come in groups more regularly by the hygiene resources and the takeaways that were provided. There's greater potential to reach and increase uptake of immunization, again, with these incentives. There was sort of a compounding success of WASH for other health issues in reducing diarrheal disease and the related burden on strained health systems. And there's also emerging evidence that supports the plausibility of improved performance of oral vaccines with improved gut health coming from reduced diarrheal disease for children in more hygienic environments, and more research is being done in that area. So just very generally, from this, the Nepal Ministry of Health has deemed this integrated model of hygiene and immunization to be feasible, and it's actually now poised for national scale up. And it's showing great potential for replication in various contexts. So now we need the momentum to bring this model forward globally. And so here we bring ourselves to where we're at now with COVID-19, and what does this mean? So we've seen the risk presented by COVID-19, as others have stated, in limiting the continuation of immunization clinics and programs. We also know that hand washing and hygiene promotion is in the first line of defense against the disease transmission, as recommended by the WHO. Yet we also know that millions of people don't have access to water or soap, or practice hand washing behaviors to fight the spread of the virus and build resilience to future outbreaks. And this is very much seen also in healthcare settings as well, with limitations on access to water and soap. Gavi has stated their flexibility to reallocate up to 10% of existing health system strengthening investments to prioritize areas of hygiene and infection control, including training of health workers. And with that too, we know that the COVID vaccine is potentially a year or more away. And we know that when it does become available, again, as others have stated, it will be in high demand, and many countries may be most vulnerable to the disease. Transmission may not be prioritized initially within this global demand. So with this evidence from the roundtable, we can see that immunization programs can be an entry point to bring hygiene behavior change interventions together. And this can include hand washing, food hygiene, and other aspects of hygiene behaviors. So what is WaterAid doing about this? So we see the urgency of COVID-19 is really, it's a catalyst of sorts for global action on WASH and hygiene integration immediately. And this is to both build resilience in health systems, including immunization programs now, but over the long term, certainly. We've been really working towards this phased approach over time, immediate, mid, and long-term responses, and ensuring a critical do no harm approach to hygiene through the pandemic, because we can't necessarily do traditional hygiene behavior training sessions that we would ordinarily be bringing people together. So we need to really be creative, and some of our country programs are already demonstrating that through use of radio, TV, social media, and other entry points like immunization to bring hygiene to the masses. And I think importantly there as well, we need to make sure that hygiene is everyone's responsibility, not only women in the home or mothers. It's something that is everyone's responsibility. So immediate actions on WASH and hygiene through this do no harm approach are really what we're looking at as sort of no regrets actions, because hygiene and required WASH can help limit transmission of COVID. While the world waits for a vaccine, it really starts with hand washing, but it doesn't necessarily end there. Improved hygiene integration could support, to some degree, we'd have to look at it further, how in continuing immunization programs when it's delivered concurrently in areas that are underserved or under-prioritized by both WASH and immunizations. The interventions can help, WASH interventions can help build resilience in society and in healthcare systems, and it's really fundamentally working towards achieving people's human rights to water and sanitation. And just lastly, I think, we're really encouraged by Gavi's flexibility to reallocate this 10% of existing health systems strengthening funding to look at hygiene and infection control more closely. And we'd really look to their leadership to encourage hygiene integrated approaches in funding flows in the Gavi replenishment, in funding flows for COVID-19 response, and building critical health system strengthening, and the eventual launch of the COVID vaccine as well. So there's lots to come on hygiene, and it's really interesting to hear how it connects with some of the challenges that everyone else has been pointing out. So thanks very much.
Thanks so much, Julie. And at this point, I just want to thank so much all of our speakers today. These were fantastic presentations, and really appreciate you guys taking the time. I know it's later in the evening for some of you. So the chat box is filling up with some questions. So please do feel free to put it in the chat box, or you can use the little raise hand emoji if you want to speak, which would also be great. Julie, since you just finished, one of the questions was for you from Michelle about how can hygiene be accomplished when some countries do not have proper sanitation systems? So what are the actions currently being taken to kind of circumvent that?
Well, honestly, this is the million-dollar question in terms of what can people do. And I think this is where as much as the entry point right now is very much around hygiene, it absolutely brings to light all the inequalities of access to water and sanitation. And so it's definitely something that we're trying to advocate for more broadly in terms of, yes, people need hygiene, but we need these basic services in order for people to do that. And I think just very quickly, I know there's through the End Water Poverty platform, there's a movement afoot to, around not shutting off people's water supplies for lack of payment, and advocating to governments for about paying water bills and things like that. So there's some immediate steps like that, but it really and truly the long-term solution is we really do need to get water and sanitation access to people everywhere.
Thank you. So 2 questions via email from Chitra. And maybe, I know, Elizabeth, you were speaking on this, and how big a challenge is misinformation about COVID-19 and how do you address it? Maybe we'll start with that question if any of the panelists have a perspective.
Yeah, if I may just say something. Definitely, WHO has called it an infodemic. There is a lot of information going around about COVID-19, many of them fake news, many of them quack cures, and there's just a lot of noise. And what we're doing in Nigeria, we have a coalition of civil society organizations that have come together to support the national response. And one of our key activities is to have a situation room, a civil society situation room. And the goal of that situation room is to, because we have partners in all the states and in the different communities, we have the access to surface information, intelligence from the communities. So as the communities respond to maybe what they've seen on social media or WhatsApp groups and things like that, and the information starts to percolate, we pick it up and try to address them across various media. When we have information about, let's say 5G, for example, 5G is a big one that even some respected men of God have been touting. So we take them back to the government and sit with them and find a way to craft responses that will resonate with the people at the community level. So it's a lot of intelligence that we need, a rumor gathering, and then quick response addressing the underlying fear, on the underlying concerns that people have about this fake news and the fake cures. So our situation room is one way that we've been able to do that, by bringing together the strength of civil society organizations to support the government response.
Thank you. Did anybody else want to jump in, or I can move on to the next question?
Okay,
Sure.
so Elizabeth here. We also have a civil society, many civil societies have come together and formed sort of a group or a consortium, and we are trying to support the government in giving the right information. However, the person who has asked the question saying, is there misinformation on COVID? I think in Kenya, there is more of arrogance and lack of trust in leadership, hence people thinking that COVID-19 is another one of the scam issues that we have in the country. And this is what has led to most people not taking it seriously until they have seen it affecting a neighbor or someone close to them. Or actually, the greatest reaction came through when we lost someone to COVID. That is when now they started realizing that the information they were being given, which they weren't taking to be true, was actually true. So the civil societies have really filled into that space. They are really, really supporting the government. We've even tried to develop native language, customize IEC materials into native languages, whereby someone who is illiterate and cannot read can still understand about COVID-19. And I think that is assisting a lot where it comes to those that couldn't even get the information or weren't able to digest it or, get it right because maybe it was in a language that they couldn't understand. So I think that's what we are able to do on our end.
Thank you. That's very helpful. I know we're getting close to time, so we'll try to get a few more questions answered, but if you have to jump off, just thank you so much for attending. We're going to be sending some resources around, including some ways for you guys to take action if this has gotten you all passionate and riled up about making a difference on immunization. So just a question from Jean-Francois regarding the cohort of children not being vaccinated in April and May. Do you have a sense how likely they are of not being vaccinated at all after the COVID-19 crisis is over because they will not be traced?
So I don't want to talk much about whether they will get vaccinated after the COVID, because we are hoping that with the kind of advocacy and campaigns we are carrying around, people will still find immunization important and continue to take their children, even now during this COVID-19. However, what we have done is that we are putting into place a defaulter tracing system or mechanism for immunization defaulters or missed opportunities for immunization. And so even if they don't get immunized now, my belief or hope is that after the COVID-19 pandemic, we will still be able to trace those children and have them vaccinated or immunized. So yeah, we have a defaulter tracing mechanism for immunization defaulters through the CHVs and the community strategy, which is already a government adopted policy. So it is not like we will be starting something new. It will just probably be to strengthen, sensitize, and continue to look for the defaulters. Yes.
Thank you, that's helpful. And maybe just a last question before we close up was from Robin in terms of why is an integrated care approach not being implemented in the repurposing of GPI and GABI resources?
Hi, it's Melissa here.
Hi.
This is a conversation that we're looking to have as within the polio program, and in countries like Afghanistan and Pakistan, even when I was in Nigeria, there is a push to provide integrated services. If you look at a context like Afghanistan, for example, where we've actually in some places suspended polio campaigns in areas that are not in control of the government, the move has been to provide and look at all different types of opportunities to provide an integrated package of services. Certainly UNICEF and our executive director had a push to, mobilize additional resources for providing water and sanitation, expanding the package of basic health services into areas where health facilities were not present, providing access, nutrition services, etc. So that piece of work has been started even before this COVID emergency. In Nigeria, in fact, Canada had provided a substantive amount of money, polio funding, in fact, to provide a package of integrated services into hard-to-reach and underserved communities, not just bringing polio vaccine, but other services like ANC, nutrition, screening and treatment, etc. In the context of polio and this pause, we are looking at how we are going to have to rethink how we deliver in some of these geographies, and how do we work with nutrition and certainly within UNICEF, because we go beyond health, with our WASH programs, nutrition programs, etc., to look at how we can do I'll call it fixed post, catch up, accelerated activities, recognizing that we're going to have missed opportunities for immunization and missed campaigns, etc. So there is work going on. There's a need for additional funding for this piece of work. But it is happening we need to respond in places like Pakistan, Afghanistan, to provide more than just polio in rebuilding trust. And I think this unfortunate pandemic also provides us, if we take it, an opportunity to rebuild trust in immunization. And we also need to look strategically at how we can provide a broader package and respond to the needs of these communities. Thank you.
Thank you so much. So maybe we're out of time, so we'll wrap it up. But if your questions didn't get answered, please do reach out to us at Results Canada, and we get you in touch and get the answers for you. I think we have our information on one of the slides upcoming, and we'll take note of all the questions in the chat box as well, and make sure that we can maybe respond to some of those when we send out the information from the webinar and the recording, as well as just some suggested ways that you can take action if you're interested. As mentioned, we're in the middle of an immunization campaign, I know in Canada, but as well as I know the UK is working on this too, and making sure that immunization is kind of not left behind in the COVID response, and that we're seeing strong commitments from donors and strong reactions from other countries in terms of how they're prioritizing immunization. So here's our information where you can get in touch with us. Just special thank you to Kenneth at Results Canada, who put all this together, and again, all of our speakers who took the time to come today. So thank you all for attending, and have a great rest of the week.